I'm chairman of TACL. I've been for, I think, 3 years. TACL is no more than a federation of 88 support groups across the country. We don't take subscriptions from those 88 support groups. We do receive some funding from them when they've finished buying their gazebos and their banners and their flags and their tables and the whatever, blankets and everything else, t-shirts. But primarily, we are the grassroots voice of prostate cancer patients and their families. Prostate Cancer UK, who we work very closely with, the man, you pay £1 for him, M&S and Men United. And I run Aylesbury Vale Group, and we do go along. We go along to MK Dons. I think I get the same league now, is it?
Yeah.
MK Dons? Yeah. We go along to MK Dons to rattle the bucket once a year, and most groups do that. So we work very closely with PCUK. They provide excellent documentation, but we believe we've got something else to offer, which is listening to what patients are telling us, trying to put together a program to answer questions that patients have, annual general meetings and workshops covering topics that patients want to talk about. This year we did erectile dysfunction and incontinence, because that's what people said they wanted to talk about. So we got leading speakers to talk about those topics, and that was very successful. So we try and reflect what patients are telling us. I've done about 11 of these this year in various places around the country, up north, northeast, northwest. And next month I'm going to Truro. Quite looking forward to that, because I'm coming back on the sleeper. And the sleeper's so cheap, When you consider the distance, I thought £79, I thought it was really good value for the sleeper. Anyway, Truro, I'm doing Cheltenham next week. And I'm sure there are others in the pipeline next year. And the idea is to talk to support groups and connect and say, this is what TACL is trying to do. I'm going to share with you what our future plans are. We're going to have time for questions and answers. We don't have all the answers. We're not clinicians, but we can talk from experience, because we've got a lot of people who have had most treatments anyone here has had or is going to have, so we can talk with some experience about those issues. So I was diagnosed end of 2009 when I was 60. 60, yeah. And I went to the doctor, my GP, getting up in the night, and he said, "Oh, come in, old chap, sit down, old chap. What's the problem, old chap, or young chap?" Anyway, he said, "What's happening?" Well, anyway, quite pally and chummy. "Oh, we'll do one of these PSA tests." I didn't know what he was talking about. If I knew then what I know now, I'd have said something differently. But anyway, something different. He said, "Right, PSA test," and it came back 4.1. I had 6 tests every 3 months. I had a test. 4.1, 4.5, 4.9, 5.1, 5.4, 6. He retired when it was 5.4, and a woman doctor, I had to move in the surgery, I had to change doctors because he retired, and as soon as she saw me and saw this, and it was 6, she sent me off to the hospital. Now, I also go to other support group meetings. So I was at a meeting in Watford a few weeks ago where they'd just done some PSA testing. They tested 73 men a couple of days earlier, and the clinician was there talking about the results. So he had a chart. He had this chart which has, you can imagine, it has 73 dots and it has these steps, what the PSA should be for each age band. And then you put the dots on there and you send red letters to people that are red, amber letters to the ambers, and green to the ones that are okay. That's how it works. And then you follow up. I'm sitting in this council meeting, I thought, oh, I'll put mine on here. So I mapped 4.1, 4.5, 5.5, 5.6. And when I realised, every single one of my results was way above what they should have been. So I asked myself, was that GP really up to scratch? Should I have been more informed to have asked the right questions at the time? I just took it as, that's acceptable. But my goodness me, Gleason 9, T3B N1, and it's the N1 that's come back to haunt me, lymph nodes, I might have avoided that if he'd sent me to the hospital when it was 4.1. Now, I don't know that, and you don't know that. It doesn't, my wife would say, "Oh, Roger, stop worrying about that. 9 years ago, 7 years ago." I know, but I just say that because I still think there's a problem. I still think not all GPs are clued up to help as much as they could. If you look at the guidelines that GPs receive from the government, I didn't bring it with me, but I promised I'd send Martin a copy. There's a Prostate Cancer Risk Management Program, PCRMP. It's a 26-page booklet that every GP is given, which is the Bible for prostate cancer for them. So any of you go in and ask a question, you can look it up and give the answer. What's it called again? PCRMP, Prostate Cancer Risk Management Program. I'll send an email and you can maybe circulate it. On page 2 of that guideline, halfway down, it says, and this was updated in March last year, March 2016, GPs should not initiate a discussion about PSA testing in asymptomatic men. In other words, unless you go in there moaning about symptoms that you've got, the GP should not start the discussion about the PSA test. Now, the workload of GPs, we know, is up here. So if you're given that sort of guidance, I mean, what are you going to do? You're going to say, well, it's not really important. And it's shameful that that sort of statement is in that guideline, because what it means is, you don't give the guys a chance, because many men wouldn't raise it. Many men are so embarrassed they don't want to talk about it. And it's up to the GP to say, any trouble? How often do you get up at night? How old are you? Do you get 3 or 4 times? Do you start and you can't stop? Do you stop and you can't start? Do you dribble? Do you want to go again? In the bedroom? Semen goes through the same pipe? Any problems? All of those sort of questions. There are ways of dealing with that to make men feel more comfortable. But as long as GPs have that guidance, it's a crying shame. If you looked at the latest Prostate Cancer UK booklet, I haven't got one with me, I'm apologising. It's a little booklet saying all you need to know, little card, all you need to know about the PSA test. And you can buy them, you order them in boxes of 100, and you give them away. If you open that, it says, I don't know the exact word, but it says something like, be careful, a PSA test can do more harm than good. And they go on to list all the side effects for PSA test, biopsy, surgery, everything is listed that could go wrong. They don't say, but have the PSA test anyway, because it's the only way we're going to find anything out. It's all we've got. And what they don't tell you is if you go to a decent clinician today, they don't send you straight into the operating theatre. They don't send you straight for a biopsy. If you went to, and I'm going to quote some hospitals because I don't know all the others, but if you went to UCLH or Radcliffe at Oxford or the Lister at Stevenage or Addenbrooke's or the Christie or John Radcliffe or QEH Birmingham and probably down here, they would give you a multiparametric MRI scan. They would give you, in essence, a 3D image, which shows you the part of the prostate that the 14 needles may not get. And when you have that as an informed scan, and you have active surveillance available to you for low-grade cancer, and you have second-line hormone therapy treatments now becoming available right up front, because it's shown that if you give second-line hormone therapies at the same time as other treatments, it's really good for you. All of that means we have less overdiagnosis and less overtreatment. So my argument would be, why not introduce scanning as screening? Or, if you don't want to use the word, sorry, I get hot flushes as well. If you don't, and a cough, I tell you, when you think every twinge and every cough, has it gone there, has it gone down? Where was I? Yeah.
Scanning.
So scanning, I think, what I would say is more informed PSA testing is what we want. In other words, have a conversation. What are the risk factors in the family? I'm more at risk because of my size, family history, maternal breast cancer, lots of questions you need to ask about lifestyle and everything else, and then you have a discussion about whether the PSA is useful, and what are you going to do about the result when it comes back. We know it's not perfect, but it's all we've got. Until something more comes along to do with the genetics and the biomarkers, we won't have anything. But I would argue that it's about time. Now, if you talk to the people in the know, they tell you that the pendulum is sort of swinging in our favour, because the powers to be at NICE and NHS England are making noises about re-evaluating the data and the assumptions that led them to say no to screening 5 years ago. And they wouldn't normally review that for another 5 years. But they are now reviewing the data. So it could be that we see something coming from that. I hope so. But that's what we have to fight against. On the train down, the lady with the bottles of water, she said to me, well, you going home? You coming home from work? You know, I said, well, we're just going so-and-so. Oh, prostate cancer, yeah, my father-in-law died of that. And she was so supportive, but so ignorant. I have to say, she's a lovely lady. Do you mean a simple blood test? Is that all it is? Do you mean you can tell? I said, well, it doesn't tell you if you've got prostate cancer. It tells you the state of the prostate and you can have further investigations. Oh. And why is it, do you think, men don't go to the doctors then? I said, we haven't got long enough to have a full conversation. But we talked about a bit about it, you know, and we have more work to do. So Tackle would like to continue to influence the powers to be. We work with NICE and NHS England. We work on the submissions committees. I work with 19 other cancer charities on the Cancer Coalition. Next week I'm off to Portcullis House in Westminster to talk about the All-Parliamentary Cancer Group and prostate cancer and what can we do to help. I've just written to Frances O'Grady, who is the chairwoman of TUC, first chairman of the TUC, because this year we were asked if we go to the Black TUC Workers' Conference in London, and we tested 153 men. We paid for that to be tested. That was a real coup. At that meeting, there was a guy from ASLEF who said, could you come and do the ASLEF delegates meeting in Bristol in May? And we went there, and I think there were 80 delegates, and we tested 57 of them. So they will, you know, they will do it if you can get their attention. So I've written to her saying, you know, what's the policy on PSA testing for the unionised community, for all your affiliated unions? And let's have a discussion. If you don't have a PSA policy, we'd offer to help you write one. And could we spread the word a bit more? So those lower socio-economic group of men, I'm careful my words, but you know what I'm saying, the people who are less inclined to go to the doctor, the people who are less inclined to talk about these issues, that's a big community who are really ignorant of prostate cancer. And we need to do something about them. Were you going to ask me something?
Oh, I've got a thing flying in front of me.
So, I felt quite good actually until last year because I had a prostate removed. I had some follow-up radiotherapy a year later, so in 2011. That's good, down to 0. I had bleeding from the bladder a year later. I spent 3 weeks in Wickham Hospital, so my bladder's half the size of yours or yours now, but you know, it's livable, I can live with that. But stopping the bleeding of the bladder is quite difficult because of the nature of the beast. It's very difficult to cauterize. Yeah, it's moving all the time. Anyway, I'm okay. So I had 4.5 years of freedom until last year when it started to rise. So when it started to rise, I had a scan, I had a choline PET scan, which is the radioactive PET scan, shows everything. They found this lymph node between the kidneys, near the spine. So I had CyberKnife, which is the latest all singing, all dancing radiotherapy regime, where you lie on the bed for about an hour, and the robot all round. It's fantastic. It goes off, changes the lens and the thing, and comes back, does loads of scans, loads of zapping. I had 3 days of that. It didn't work. It grew to 10 millimeters. Another scan. They found 4 more here. I think it's called the periaortic area. So he said, well, there's no point in surgery or radiotherapy because we can't do all that sort of stuff. There are probably other lymph nodes somewhere in the body that, you know, floating around if you find those 4. So we'll put you on hormone therapy, which I really wasn't looking forward to. But a second colleague, who is on our clinical advisory board, who works at University College London, and my clinician works at Mount Vernon, North London, Northwood Cancer Centre, but she works at UCLH. She said, well, if you came to my clinic, I would just give you the tablet to start with. I'd give you bicalutamide. So I went on to bicalutamide, hormone tablet, for a while. November? Yeah. January, that stopped working. PSA started to climb again. Right. Now the injection. LHRH analog, in my case it was Decapeptyl injection in the bum, but you can have the thing under here, you know. You had Zoladex or whatever. I had the injection. So I had that 12 weeks ago, and PSA's gone from 2.6 to 6.8. So it hasn't worked. So I said to my oncologist, what's happening? Because, first of all, the radiotherapy doesn't work. Then the hormone tablet doesn't work. Now the hormone injection doesn't work. You know, what guarantee is there, what confidence would I have that the next line, which is likely to be enzalutamide, second line hormone therapy, that would work? And I don't have the answers. I'm having another choline PET scan on Monday. That got me into trouble on Monday. I'll tell you why in a moment. And then I'm seeing him in a couple of weeks, so hopefully I've got a whole list of questions. It's very difficult at the moment because I don't know what the future holds, but you know, you have to stay positive. For my daughters, you have to stay positive. You know. But when she phoned me the other day and said, I've got your appointment for your PET scan, she said, they only do it on Mondays and Fridays. She said, I've got an appointment on Friday. I said, I'm sorry, I'm coming back from Plymouth tomorrow. Oh, she said, I've got an appointment on Monday. I said, well, I've got 3 meetings at Prostate Cancer UK on Monday that I set up. But I'm free on Friday. So she said, right, we'll make it next Friday. And my wife came home. My goodness, did I get it in the neck. Do you mean to say you could have gone for a scan on Monday and you decided to go to London to try and help other people? What about putting yourself first? And then my oldest daughter said, Dad, what are you doing? Put yourself first. And I got it. Oh, my goodness me. So I changed it back to Monday. So what I learned from that is actually everyone around you really does care. But the other thing that I learned, I'll get through this bit, this is quite difficult. About a month ago, when all this came up, my mother, who's 90, came to visit us, because I have a granddaughter, 2.5 now. And she came for the weekend, and my mother did not know that my prostate cancer had returned. I was thinking, how do you tell a 90-year-old without telling them everything? She doesn't need to know all the details. I would have said, Mum, I was on a treatment, you know, it's not quite working as well. I'm going on another treatment. I'm sure everything's fine. Don't worry, blah, blah, blah. I went out to Tesco's to get some stuff for my weekend. When I came back, my mother was in tears. My wife was absolutely fuming. My wife had told my mother everything that had happened over the last 6 months. So my mother's reaction was, what? Does that mean, like Dad? And my dad died of cancer of the esophagus from being a tug skipper on the Thames and all the soot and the smoke in the 60s and got down here. But it took 50 years to... and he gave up. He couldn't do chemo in the end. It was too difficult 20 years ago. He said, are you going to opt out like Dad did? You know, are you going to have the chemo? I said, Mum, I'm not near chemo. I'm not near chemo. She said, well, I thought you were cured. I don't use the word cured, but she thought I was cured. And then my wife started. My wife said, how do you know this guy at Mount Vernon is the best guy you could be speaking to? How do you know that someone else doesn't have a better opinion, better treatment plan? Why don't you go to America and find out all the latest stuff? And then, anyway, so why don't we spend some of our savings, and like your brother, who has private health insurance through his company, go down to Harley Street and get the best treatment we can privately? Oh, my goodness me. I didn't know which way to turn. My wife, it was the weekend from hell. Now, I don't blame my wife or my mother, particularly my wife, because all of that tension came out in that weekend that had been building up for some time. So why I'm telling you that story is, I have a very fervent, strong belief that prostate cancer affects more than the patient. You have to help the family environment. And I once went to see a guy who was diagnosed with advanced prostate cancer on a Thursday morning last year, and I get referrals from Stoke Mandeville. So I go and see this guy. You wouldn't think there's anything wrong with the guy. Tall, thin, skinny guy, keen cyclist, fit as a fiddle, advanced prostate cancer. So I said, well, I've got some leaflets here. I felt really useless. As soon as I started speaking to him, he really wasn't interested. But his wife, well, okay, so what are you going to do for us then? What do you mean? I said, well, there are, I said, you know, we've got people in the group who have advanced prostate. What are their names? Give me their names. What's the phone number? Can we phone them now? Can we phone them? I said, and I made a mistake of saying there are also trials. Oh, trials? Can we go on the trial? My goodness me. And she said to me, what are we going to tell the children? And what am I going to tell the neighbours? And I thought, I didn't say it, I thought, what are you going to tell the neighbours? But I realised, for her, in that community, her conversations, I say over the fence, probably doesn't happen like that now, probably on the phone, with the lady next door, was very important to her, talking about husband issues and problems, and she didn't know what she was going to say to the woman next door. And that's another example of where you need to think holistically and say, well, how can we help that person and the families and the carers get to grips with it? So that's what we're really interested in. So lots of examples, there are lots more, but basically we're trying to do all of that. So what we do is work with the NICE and NHS. I think we were quite successful. We were campaigning to bring forward the availability of second-line hormone therapy before chemotherapy with abiraterone and enzalutamide, and we were successful in that, working with other charities. And I think we're also pushing at the door for better informed testing and screening. So I'm hoping that something comes of that. Now, as far as the future is concerned, we've got a really good idea. Well, I have anyway. I don't need to go to Walnut Outdoor. You know what Walnut looks like, don't you? Actually, no, I think I will.
It'll take long for Roger to get his nuts out.
Got Brazil.
Like that from Christmas. We were trying to buy
Wrong
one
shape.
the other day. And he goes,
What have you done with my walnut?
Not, I've not had your walnut.
see his pocket.
Hands up your walnut. Got your fly here though.
He's lost his walnut.
There it is, in the nutcracker.
We've got a picture. We've got a picture of one.
That
haven't
one
we?
wedged in the nutcracker.
I've got one on the car.
Sorry, guys.
Don't go there.
I only say that because
It's a bouncy button.
there's a guy from Tesco. The guy from Tesco gave it to me. In fact, he gave me a bag of walnuts. I said I only want a couple for things. Anyway, in April or May next year, we have a major campaign, Cycle to the Moon. We want to cycle, or we want people to cycle, 250,000 miles, which is the distance from here to the moon, at £1 a mile, across our 88 groups, or 15,000 members. And we don't mind whether it's spinning classes, road racing, BMXing, outdoor trails, in the gym, underwater. When I go to Aquafit, which I have to do twice a week now under orders, and I lie there and I cycle before I do my Aquafit. I do about 100 of these cycles, and I thought, well, if I had all of those, I wonder how much I'd cycled. Maybe in a week, maybe a few miles, so a couple of pounds or whatever. So we don't mind how we raise it, but the idea is to raise this money to keep us going for the next 3 years. And we want all the groups involved, so that your children and grandchildren, and you'll be given all the publicity. We're just recruiting someone to run the campaign. We can actually raise a lot of money. What we want to do with the money is cycle to the moon, save a dad. Last year in Crewe, we went to a secondary school in Crewe, into the science lesson. We got permission to go in. We took a walnut. We gave a walnut to every child in the science lesson. And we said, do you know what this represents? Of course, they didn't know what we were talking about. But we said, right, homework this week. Go home, find out who in your family has had prostate cancer or has been suffering from prostate issues. Find out all you can about prostate cancer. Find out about the prostate. Come back next week, have a discussion. Of course, all the 14, 15-year-old boys came back with all these lurid diagrams of everything that, that you can imagine. But nevertheless, had this discussion. And had a discussion about what prostate cancer is and why it's important to identify some of the symptoms, but also as important to have a baseline test at a certain age, even if you don't have symptoms, which is what we're trying to achieve. So we said, right, we sent the boys, particularly the boys, home to say, Dad, do you know what this is? Dad, do you know what it's for? Dad, do you know where it is? And Dad, please go and get tested. Because the age of that father is exactly the right age for a first baseline test for PSA. And we reckon that if we can work through secondary schools and the next generation, they are the ones that will influence their parents. Because you know, if a child comes home and says, Dad, I really think, I mean, my daughter said to me when I smoked cigars 25 years ago, she wrote on the packet, Dad, this is your last cigar. Dad, you will die. Dad, we love you. Please stop. And I stopped. Well, if someone said, Dad, I don't want you to die, you know, I know, if a child came home and said, Dad, do you realise that 1 in 8 men are going to die of prostate cancer? So 1 in 8 of the fathers in that science lesson are going to die from prostate cancer. They're going to get prostate cancer. And we don't want that to happen to you, so would you go and get tested? I think that's quite a powerful message. How we do it, I do not know. I can just imagine going to the powers that be to say, you know, we want 5 minutes on the national curriculum, because there is 5 minutes on the national curriculum for breast cancer. In the PSHE curriculum that all schools have to follow, there's 5 minutes on breast cancer, there's 0 on prostate cancer, which is the most common cancer in men. So we think that's quite a good idea if we could use the money to do that over the next 3 years. And that's some of the things. We got good feedback that that would work. So we're now getting someone on board to try and manage the campaign. So I'm at a bit of crossroads, wondering what the future holds. I don't know until I talk to the consultant what's going to happen. I remain positive. I'm remaining positive. I find it much easier to stand here talking to you than actually deal with my own situation, I'll be honest. Much easier to give consultancy to someone else than take it on board yourself. But I'm learning, and like Monday was a good learning lesson for me. You know, put yourself first. Why the hell would we be going to London for 3 meetings for other people when you could be going to have your scan? So I said, yeah, okay, sorry about that. That was it. Now, Hugh, 12 years ago, Hugh was given 18 months to live. And here he is, fitter than I am. He's been through practically every treatment there is. So if you want to ask any questions, he's got some experience. We also have experience of people in the group and around the country that are having various treatments. And our aim is to say to these people, you are entitled to the best possible diagnosis and treatment. And if that's not available locally, you are entitled to a referral to go and get it somewhere else. But unfortunately, not every man knows that. And not every man would want to discuss that. So we've got a lot of work to do through our support groups and the connections with local hospitals. Right. Any questions for me? I've said quite a bit. There must be some questions about your, well, if you don't want to talk about your own situation, any observations? I mean, do you think we're doing the right thing? Do you think this is the sort of thing we should be doing? Do you think there's more work to be done? Did my comment on GP surprise you? Do you have people that don't have the best treatment options available to them? I've just written to the head of NHS commissioning about radium-223, which is what Hugh's having at the moment. That's a radium treatment for bone, where it's gone to the bone. And NHS has said, in London, we've got 7 centres that are accredited to give you radium-223. We're only going to make it available in 3 of those, and all that, they're all south of the river. So if you're in North London or Hertfordshire, and you're really quite in pain with this, many people are, if you've got the bone problem, they've got to travel over an hour to get to the clinic, and an hour back. And we said, look, it's not going to cost you any more. The staff are there, the stuff is there, just open it to these other clinicians. And we don't know whether it's going to happen, but that's the sort of thing that we do, to try and help more people get better treatment. If you don't think it happens, let me quote you one more example. We just opened a group in Daventry near Coventry, and Steve, lovely chap, he's joined us. He's the 88th group, and he was diagnosed last October with advanced prostate cancer, and he went to see his oncologist and said, it's been a long day. His oncologist said, right, well, I will put you on hormone therapy, because at a PSA at that level, we can't give you anything else until it drops below 10. We're not going to consider surgery or radiotherapy until your PSA drops down to a more acceptable level. And with hormone therapy, we'll see how it goes. Well, in June this year, it went down to 16.2. So I went back to the oncologist and said, right, is that low enough? He said, no, that's as low as it's ever going to get. Carry on with the hormone treatment, you're on your own, basically. That's it. He came home on the Tuesday night, had a family discussion. You know, in a good way, he's at the leading edge of risky surgical procedures. They went privately to see him on the Friday, husband and wife. He had all his cancerous lymph nodes removed. surgically. He's now running half marathons and he's well. Now, I'll tell you that story because the questions that raised for me, that raised. Was that oncologist right to just say to him, you're on hormone therapy and deny other treatments? Was there a second opinion? Was it right that a 16-year-old son should Google his dad's condition to find out what's wrong? Was it right that you should have to pay privately to go and see someone to get the treatment? And obviously he could afford it. And all of those questions, you think, well, goodness me, can that happen today? Well, it does. So then I then thought, well, if he can have it, I can have mine. I can have mine surgeons. So that's one of the questions I want to ask. I think I know the answer and say, no, you can't. But another oncologist did say to me, well, if you can't have them surgically, you can have radiotherapy. I've never had radiotherapy here. You can have radiotherapy here, but we'll see. So we try and promote people having the confidence to go and ask and get referrals. And Hugh has changed consultants. We had at the AGM, we had an excellent speaker on incontinence and erectile dysfunction. And one of our trustees, I won't say which one, who suffers from a waterworks problem, he liked the guy so much, this guy from University College London. He went back home to Essex. He got his GP, his oncologist, to give a referral letter to Julian Sharp at UCLH. He's now going to talk to him about the next stage of slings and sphincters. And he would not have done that if he'd not known that this guy was willing and able to offer that sort of service. And his claim to fame is that he can make any man dry. That's quite a powerful claim to make.
Can I just say, Roger, if anybody's interested in seeing the talk, and it's really worth watching because it's quite funny as well. It's brilliant. It can be downloaded from our website, from Tackle Prostate Cancer, and it's really well worth watching.
This is the guy that can make anybody drop.
Yes. Yeah.
Julian
Sharp.
SH.
Yeah.
He's a
SH.
AH. He's a urologist at University College Hospital London.
Yeah.
He spends most of his time at the Royal Orthopaedic Clinic in North London because most people that have fractures of the pelvis and back problems inevitably have bladder problems. So he spends a lot of time there. He also goes out and operates privately in the Middle East for people that can afford it, the Arabs and that sort of thing. He does that. And he's also he's got legal training, so he represents other doctors. But he's a very genuine guy. He plays the ukulele, he's a very funny guy. But he talked to us about the stigma, the issues, the options, and built confidence, I think, in everybody in that room. That you can actually go, if you're wet, you can go and do something about it.
It's the best talk I've ever heard.
Where is he based?
University College Hospital, London. If you Google him, you'll see where he's both his NHS and his private practices are. He's 45. At the moment it's 50, age 45. Certainly, maybe even 40 if you're black, 1 in 4, would be the best step forward. And then if you have an informed discussion about that, see, a doctor at Oxford University, a lecturer at Oxford University who teaches GPs, who came and talked to us, he said to me, if a man comes to me age 40 with a PSA of less than 1, I could tell him with a 99.99% certainty he will not die from prostate cancer. So you can already rule out, and in that case, he need not come back for a test maybe for 5 years. But if it is raised, you come back, in 2 years or 1 year or 6 months. So you make an informed choice based upon the risk factors. Are there other people in the family? On the maternal side, is the BRCA2 gene there on the maternal side? Because breast cancer can affect it as well. And there are lots of issues you need to discuss. But all the time the doctor is not incentivized to ask the question in the first place, it's down to you to ask. And he has every right, I think, to turn around and say, look, you're worrying about nothing. Because he can't be bothered. Because he's got a stack of things this high, and prostate cancer is this low. And he probably sees one person a year with prostate cancer. Big issue, but we must talk about it. We must share it, talk about it, and hopefully get people to change their views. And then you can start the discussion. It is the only test we've got, and to deny men that only test, to have a discussion. I mean, there's lots of things happening behind the scenes, and if you get it early, low-grade prostate cancer, they're now talking about not calling it prostate cancer. They're talking about Gleason 6 being called prostatic disease, and go on active surveillance, which is fine. So, there are movements, and it's not is not necessarily cancer. Hugh, the percentage of people with prostate problems that have cancer is what, 1 in 20 or something?
Yeah.
Is it?
Mm.
So enlargement of the prostate, or inflammation of the prostate, or infection of the prostate is much more common than prostate cancer. So you can put a lot of people's minds at rest if they're struggling to go, because it may not be because of cancer.
So the other,
The other thing I wanted to say is we were talking at lunchtime about what makes a successful support group, and I was telling you coming down about the awful example. I went to a hospital recently. I went to a support group recently that had it in an education centre next to the hospital. And I went in there to give a talk, and I went in there and there were these round tables, it was like a wedding thing, 10 round tables. And on each table there was a label, and it said brachytherapy, chemotherapy, radiotherapy, radical prostatectomy, chemotherapy, or a whole range of things. And I said, well, what are these labels here then? She said, well, we think people that have the same problem like to sit together. I said, oh. So tell me, about 40 people there, why is the table at the back empty? And do you know what was on the table at the back? Chemotherapy. Oh, she said, because people don't want to sit there because they're near the end. And nobody wants to. And I said, can we have a discussion about afterwards? And I said to her, look, my strong advice to you, get rid of the bloody labels. Let people sit where they want to. Let people talk to who they want to. And don't label people. And all the time you have that sort of thing. And it's at the back of the room. You know, it just sends the wrong message. So anyway, we have, this may sound strange, but in my group, there are some men-only meetings because the men are meeting the local football club for a pie and a pint, and that's what they want to do, have a chat, pie and a pint. Then we have evenings, we have quiz evenings and social evenings and barbecues and like that. Right, so when all the partners come along, that's fine. This woman walks in. Right, she said, I'm representing Sing with Cancer, Sing for Cancer. Tenovus, Tenovus, Welsh charity, bringing it into the UK. There's a trial underway between Imperial College, Royal College of Music and Royal Marsden, setting up a choir at Sutton and one in Chelsea to try and demonstrate that singing helps. And if we're successful, there's a chance NHS might fund it throughout the rest of the country. So I want to try it today. So stand up, everybody. She said, I'm not going to ask you to do it. She said, stand up, everybody. So we stood up. I thought, I can't sing. What is all this about? I don't know. Right, she said, stand up, now the sound, from here, all these things. Right then, we're going to sing now, we're going to sing. I looked round and I thought, no, I'm not going to sing. Oh, this is terrible. Right, she said, I'm going to sing something very simple. She said, and this lady was trained classically, I realised afterwards. She said, right, well, we're going to sing something simple, and I can't sing, so forgive me. She said, we're going to sing, Bella Mamba, Bella Mamba, Bella Mamba, yay. Bella Mamba, Bella Mamba, Bella Mamba, yay! Bella Mamba, 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 yay! I said, oh my goodness me. So anyway, he started going, so we started singing, Bella Mamba, Bella Mamba. Now come on, she said, come on, breathe. So we got into it, and then we sang a couple of rounds. Right now, she said, split into two. There's 15 here and 15 here. You start, Bella Mamba, Bella Mamba, Bella Mamba, yeah. Bella Mamba. So we did the round, and it all got confusing. Right, she said. Now, we're all standing there. I want you to sing while you're doing this. I don't mind whether it's this or this. What's going on here? So she said, right, sing. And we all had to do this. And I tell you what, we sang 10 times better. I don't know what it was. Maybe your mind, maybe the man, this business. But, we're Bella Mamba, Bella Mamba, Bella Mamba, yeah, and we were really into it. And after about 25 minutes, finished, I thought, crikey. I honestly felt like a new man.
If you want the CD, see me afterwards.
And I don't know whether it was the endorphins, or the adrenaline, or the breathing, or the exercises. I think it's possibly also just getting rid of all your inhibitions and singing together. And I reckon there's something in this. It really, really helped. And I would say, I learned something that night, and I thought, if I had the opportunity with a group of people, and I can't sing, I would certainly get her to come along and wake people up. That was really good. Anyway, that was an aside, so I suggested to them they could do a lot worse than ask more questions about the mental and psychological aspects. I'm firmly convinced that the emotional, mental, psychological aspects of prostate cancer are a lot worse than the actual physical manifestations. Unless you're really struggling with erectile dysfunction as a young man, or unless you're wet, Those are two exceptions. But generally, people still struggle with the emotional side of all of this.
I talked to last year as well man's clinic, and I asked for this, and that's where they identified it. What you said about the two issues that we have, like erectile dysfunction and wetting, right? I'm okay in that area, still okay in that area still. But one thing I didn't refer to as, I'm getting upset now, was the psychological side of it. And I've never even thought about it, but you just mentioning it has really brought it home to me.
It is. What can I say? I think we've had some talks at our conferences from people who specialise in living with prostate cancer, and Macmillan are quite good at this. They recognise the emotional, psychological aspects, and I think more needs to be done to recognise it and to offer some sort of counselling to people to try and get through it with the family around you, so everyone is empowered to help you. Many wives and partners don't feel empowered to ask the right questions because they don't want to upset the man. But if you're open and talk about these things and upfront about it, it really does help. And my stupid singing example is a simple example of where something that I thought was useless actually worked. And for other people, it might just be having a conversation with the family, but a structured conversation around what's really happening up here, for them to understand. And then the children and the wife can actually help you. And I just think I see that happening more and more. We need to do more and more because it's a untapped area, I think, of work.
It is, but I'm just being like, in the year I've had it, I don't have a partner, I'm on my own, right, so I'm actually coping it with myself, right. I talk to people, colleagues at work, they take an interest, you must keep us informed, Dennis, and all this type of thing, but at the end of the day, I get the impression that, it's something you have to manage on your own, when you've got no one to share it with.
Well, why don't you have a word with your, clinical nurse specialist?
Can I just say, someone like Macmillan, the Mustard Tree at Derriford, have been fantastic for me. On the psychological side, I've had counselling, free counselling, one-to-one. I've got some clients cancer with limited lifespan, and that's been tremendous for me to see past that. But often, even when you do have a partner or family, and you have those conversations, it's difficult to have those conversations with them. It's sometimes better to have the conversation with someone outside the family who understands. This is a nurse, a specialist nurse, who actually is experiencing counselling, and it's a really good outlet beyond the family even to have those conversations, and work wonders for me. I recommend
That's
it.
the mustard.
The mustard tree in Derriford
It has been
Hospital.
mentioned, Jill has mentioned it,
Yeah. It's tremendous.
Excellent.
I think I'm just...
Do talk to someone is what I'm saying to you. Don't just talk to as many people as you can. And someone like the counsellors at Mustard Tree in Derriford will be a great help to you, I think. And you'll be able to see beyond where you are now.
I think I'm just getting...
You're excellent.